Hi, thank you all for joining us today. I'm Sarah Lovenheim, Assistant Secretary for Public Affairs at the Health and Human Services Department. This call today will be on the record. Today we will hear from Secretary Xavier Becerra. Then we will hear from the White House Coordinator for Monkeypox Response, Robert Fenton, followed by Don O'Connell, Administrator for the Administration of Strategic Preparedness and Response, followed by Dr. Rochelle Walensky, who leads the Centers for Disease Control and Prevention, and then Dr. Dimitri Daskalakis, Deputy White House Coordinator of the Monkeypox Response, followed by Commissioner Robert Califf, who leads the Food and Drug Administration. Please reserve questions until the end and kindly line up to ask one at any point during the call by pressing *1. With that, I'll turn to Secretary Xavier Becerra. Thank you.
Thanks, Sarah, and thanks everybody for joining and being patient. My understanding is there are a lot of folks who try to get on the call. Lots of new developments, lots of speakers, so I'll get right to it. The latest news, the latest numbers, well, there are some 6,600 reported cases of monkeypox in America. Last week, by comparison, when we did another press roundup, there were about less than 5,000 cases. As I mentioned last week as well, we had designated some 1.1 million vaccine doses that would go throughout the country. And now, today, we can report that we've delivered more than 600,000 of those JYNNEOS vaccine doses to our partners, state, local partners, tribal and territorial partners throughout the country. Administrator O'Connell will be able to give more detail on that. And on testing, we now have the capacity to administer some 80,000 tests per week. That has continued to rise, and we continue to try to encourage Americans to seek out a place to be tested. On treatments, for those who are infected, we have deployed at this stage some 14,000 treatments of TPOXX, a treatment that has been shown to help with those who have monkeypox. And we have, as I think we announced last week, roughly 1,700,000 of those treatments available in the Strategic National Stockpile. On education and outreach, we continue to talk with clinicians, public health partners, and affected communities daily. And I think there, Dr. Walensky and CDC can give us more detail. And this week, of course, the President made a very important announcement of his new White House Coordinator for Monkeypox Response. He and the Deputy Coordinator will be coordinating this response, and we're very much looking forward to working with them under their leadership to make sure this whole-of-government response keeps us ahead of the virus and helps us contain the spread and outbreak. In light of all of these developments and the evolving circumstances on the ground, I want to make an announcement today that I will be declaring a public health emergency on monkeypox. We're prepared to take our response to the next level in addressing this virus, and we urge every American to take monkeypox seriously and to take responsibility to help us tackle this virus. With that, let me turn it back to Sarah.
Thank you, Secretary. We'll now at this time hear from the White House Coordinator for Monkeypox Response, Robert Fenton.
Thank you, Secretary Becerra, for your opening comments. President Biden appointed me and Dr. Dimitri Daskalakis, whom you'll hear from in a bit, to lead the response for the monkeypox emergency. For 2 decades, I've overseen emergency response operations at the national scale on major federal efforts, including setting up the first mass evacuation vaccine sites after COVID-19 during the height of the pandemic, and responding to also natural disasters like wildfires. These types of large-scale operations and strategies, coordinated across agencies and jurisdictions, is the work that I've done throughout my career. Together with Dr. Dimitri and our partners from HHS and across the federal government, we will leave no stone unturned in our efforts to combat this virus. We will deliver for all impacted individuals across our country and work to end this outbreak. The team has already committed to pulling every lever to combat this virus. And as you heard over today, 600,000 vaccines to communities across the country. And we have many more on the way soon that will be briefed later. We scaled testing from a capacity of 6,000 tests to now 80,000 tests per week, and we've taken critical steps to make treatments more available to more people. But this virus is moving fast, and I'm sorry, I hit the wrong button. But this virus is moving fast. This is a unique outbreak, and that is spreading faster than previous outbreaks. That's why the President asked me to explore everything we can do to combat monkeypox and protect communities at risk. As the White House coordinating team, we will be scaling our operations and coordinating logistics efforts. We will be coordinating actions across agencies and wrapping up communications with jurisdictions and state and local leaders so that we can be the partner they need in this fight. Together, across the federal government, we will continue to strengthen our all-hands-on-deck response. We are going to apply lessons learned from the battles we fought, whether it be from the wildfires to COVID responses or to measles. We plan to be responsive leaders, focusing on tackling this with the urgency this moment warrants. And today, the key actions we are announcing will allow us to further accelerate these efforts. This public health emergency will allow us to explore additional strategies to get vaccines and treatments more quickly out to the impacted communities. And it will allow us to get more data from jurisdictions so we can effectively track and attack this outbreak. So now I'd like to turn this back over to our HHS colleagues. Thank you.
Thank you. At this time, we'll turn to Administrator O'Connell from ASPR.
Thanks so much, Sarah. So thank you and good afternoon, everyone. I'll just take a moment to briefly provide an update on our vaccine strategy. In total, we have made more than 1.1 million doses of JYNNEOS available to our state and jurisdiction partners under our national vaccine strategy, and we have secured 6.9 million doses in total. Of those, we have shipped, as both the Secretary and Bob just mentioned, more than 602,000 doses to states and jurisdictions. This is an increase of 266,000 since just last week. Also last week, we announced the allocation of 786,000 doses of JYNNEOS, significantly increasing the supply of monkeypox vaccines available to states and jurisdictions. We opened the first round of ordering against those 786,000 doses on July 29th and began shipping the first order doses earlier this week. We continue to ship these doses out as states are ordering them, and we're doing so quickly, in most cases within 30 hours of receiving the order. We plan to open the next round of ordering on August 15th. And as an important reminder, states and jurisdictions that have used 90% or more of their current allocation will be allowed to order additional doses sooner than August 15th. It's important for us to get these vaccines out as quickly as possible to those places that are using them. And we continue to work with our supplier, Bavarian Nordic, to accelerate delivery of doses to the greatest extent possible, while also ensuring high quality and safety standards. Along these lines, I'm pleased to share that we will receive another 150,000 doses in the Strategic National Stockpile in September. We expedited those doses that they were previously scheduled to arrive in October. We anticipate continued delivery of additional doses in October, November, and December. In summary, we continue to do everything we can to make as much vaccine available as quickly as possible. Sarah, back to you.
Thank you. And now we will turn to Dr. Walensky.
Thank you, Sarah, and good afternoon, everyone. Today, I will speak to how the Public Health Emergency Declaration will enhance our nation's response to the monkeypox outbreak. PHE strengthens capabilities at all levels, particularly locally. It may provide access to resources and flexibilities, enabling personnel to deploy to the outbreak and potentially increase access to care to people who need it most. Importantly, this declaration will also help us continue to expand public health's ability to expedite data sharing so that we can have comprehensive and timely data available to inform public health decisions. We're grateful to the jurisdictions that have already agreed to share data on monkeypox. 51 have already signed data use agreements with CDC, which will make vaccine administration data available as part of their allocations. The public health emergency may provide the justification that the remaining jurisdictions need in order to sign their agreement. Additionally, it enables CMS authorities that can provide us with more detailed data around both testing as well as hospitalizations. I also want to speak briefly about two of the other pillars in our response strategy, education and testing. We've worked to put resources into the hands of people at highest risk of contracting monkeypox to allow them to protect themselves directly through social media and through trusted partners in communities across this country. The public health emergency is going to mobilize additional boots on the ground to help educate people about actions they can take to limit their exposure as vaccines become more widely available. We've made important strides in expanding access to testing and making it convenient for providers. We're seeing more tests come in than at any other point in the outbreak, and key to that has been our outreach to clinicians. The public health emergency further raises awareness about monkeypox, which will encourage clinicians to test for it. CDC will continue our aggressive and comprehensive response to the current monkeypox outbreak. We will gather and share information about the outbreak and work with jurisdictions, healthcare providers, and impacted communities to educate and make resources available. We continue to, of course, welcome ideas on how and where we can improve our outreach and are grateful for our close public health partners' collaboration in delivering these messages hand in hand with us. Back to you, Sarah.
Thank you. And now we will turn to Dr. Daskalauskas.
Thanks, Sarah. I want to start by saying I'm thrilled to be on this team leading the work, serving as the Deputy Coordinator of the monkeypox response, working closely with my colleague, Bob Fenton. As the Director of HIV Prevention at CDC, I've been embedded in this response to monkeypox since the earliest days of the outbreak. And I'm really looking forward to working with this team to scale our operations, efforts, and further accelerate and strengthen the robust federal response. By training, I'm an infectious disease doctor who's dedicated over 20 years to HIV treatment and prevention and have had special focus on the LGBTQAI+ population, and I've worked in the community, academia, as well as in public health. So not only do I bring experience working on this virus and the federal government's response to this role in the coordinating team, I've experienced an emergency response, having led response efforts during the COVID-19 and measles outbreaks in New York City. And we know that that is an area that has been ground zero for this current monkeypox outbreak. I also, for nearly 10 years, have led some of the nation's largest public health programs around HIV and STD prevention, and have been working on public health issues affecting the LGBTQ+ community throughout my career. So while we know that monkeypox is not exclusively a sexually transmitted virus, we also recognize early on that this virus is spreading more rapidly and differently than we've seen in prior outbreaks. And that's why from really the earliest days at the CDC and across the federal government, we worked quickly to ramp up testing, vaccine availability and production, and engagement with the LGBTQI+ community, where we saw this virus spreading with the goal of sharing the critical information around the symptoms of monkeypox and the best practices to stop its spread. So I want to be really clear. That work has been aggressive, responsive, and ongoing since day one. It has included working directly with the communities most affected by this virus, communicating nonstop with public health officials and community health centers and community-based organizations serving LGBTQI+ individuals, partnering with social media companies, organizations, trusted messengers, and influencers to get messages out to our communities through the networks they listen to, and working early on in this outbreak with event organizers to make sure information about the virus and how people can protect themselves was on the ground around large gatherings and events this summer. It's exciting, and today's actions will allow us to meet the needs of communities impacted by this virus and those at risk, and aggressively work to stop this outbreak. So in the coming days and weeks, we have plans to provide technical assistance to state and local health departments to develop and ramp up non-stigmatizing messaging as they prepare for any large gatherings in the coming weeks and months. Develop monkeypox-related training content for sexually transmitted infection and sexual health providers. Provide technical assistance, outreach, and training on contact tracing to providers and groups doing this work in jurisdictions across the country. Reaching out directly to networks of providers to encourage broader use of testing so we can better understand the scope and transmission of this virus. Work with partners to deliver up-to-date information on monkeypox prevention and resources, including behaviors and actions that those in the gay, bisexual, and other MSM or men who have sex with men networks can take to limit their risk of exposure. And, of course, critically, listen to community partners, leaders, and impacted individuals to gain insight and feedback on how we can improve and scale our response in a community responsive way. These are just some of the actions we're taking to aggressively respond to and combat this virus, and work in partnership with individuals, local leaders, public health officials, and the LGBTQ community on the ground across the country. I'm going to turn it back to Sarah, my HHS colleague.
Thank you so much. At this time, we'll turn to Commissioner Califf.
Thanks, Sarah. Since the early stages of the monkeypox outbreak, the FDA has been fully engaged on multiple fronts. In recent days, it's become clear to all of us that given the continued spread of the virus, we're at a critical inflection point, dictating the need for additional solutions to address the rise in infection rates. The goal has always been to vaccinate as many people as possible, and for our part, HHS has been working closely with the manufacturer to accelerate the availability of additional doses as quickly as we possibly can. In the meantime, we've identified a potential solution that would allow us to significantly increase the number of doses available to administer. To help close this gap, we're considering an approach for the current doses of Jynneos that would allow healthcare providers to use an existing one-dose vial of the vaccine to administer a total of up to 5 separate doses. This approach, which we're referring to as dose sparing, would change the method of administration for Jynneos, which is currently administered subcutaneously. Under the proposed approach, a fifth of the current vaccine dose would be administered intradermally. There are some advantages to intradermal administration, including an improved immune response to the vaccine. It's important to note that overall safety and efficacy profile will not be sacrificed with this approach. Please know we've been exploring all scientifically feasible options, and we believe this could be a promising approach. It's important to note that we'll not be sacrificing the high-quality regulatory standards that Americans have come to expect. Our ability to continue allowing safe, high-quality products for communities nationwide has and will always be top of mind. And we'll continue working with impacted communities to ensure they have all the information they need to make informed decisions. Importantly, if you have the opportunity to get the Jynneos vaccine, please consider getting your first dose immediately. Addressing the monkeypox outbreak is a top priority for FDA. We look forward to sharing more information on the dose-sparing approach in the days ahead. I'll turn it back to Sarah now.
Thank you. And as a reminder, at this time, we will turn to Q&A. You can hit *1 on your phone if you have not yet signed up. We'll call first on Mike Stabi.
Thank you for taking my question. A bunch I'd like to ask, but if you could say, so how many doses do you need? Have you done a calculation? I know you talked about how many you're providing, but how many are needed to meet the current demand? And if Dr. Califf could say a little bit more about intradermally, what are you proposing, that it be a shallow injection, one between skin layers rather than deeper? What does that mean? And then could you also say, if this becomes endemic, what's the plan? Is there going to be more funding, more permanent funding to local health departments to handle that? Well, what's the plan if the immediate response doesn't take?
Thanks, Mike. I'm going to turn first to Dr. Walensky and then to Dr. Califf.
Yeah, thank you, Mike. So when we look at the population at highest risk, we're looking at both those who are living with HIV, who are men who have sex with men, as those who are high risk for HIV by virtue of the fact of their eligibility for pre-exposure prophylaxis for HIV. Summing those two populations together, we estimate that there are about 1.6 to 1.7 million people who are at highest risk for monkeypox right now, and that's the population we have been most focused on in terms of vaccination. Thank you.
Yeah, this is Rob Califf, and I'm a cardiologist by training. I'm used to sticking needles in people, but when we first talked about the cutaneous intradermal administration, it worried me a little bit that people might not be able to do it. But then Dr. Walensky reminded me that the PPD test, which is routinely used in public health clinics and many other settings, is administered by many, many healthcare workers every day. So it really means basically sticking the needle within the skin and creating a little pocket there into which the vaccine goes. So this is really nothing highly unusual. It's done in other situations routinely. So we're very confident about the administration of the dose.
And at this time, we're going to turn to Jeannie Bauman from Bloomberg.
Hi, yeah, thank you so much for taking my question. Now that there's an official public health emergency, I'm wondering if there have been talks with the makers of Tembexa or some other smallpox drugs to maybe bring forward new therapies under an EUA. And then also I know that TPOXX is available under an expanded access protocol, and I'm wondering if there are plans to collect more robust data like under a clinical trial. Thanks.
Turn to Commissioner Califf.
Yeah, thanks, Jenny. Yeah, you combined a couple of things there. First of all, I'd say, Dr. Peter Marks is on the line, and across the FDA, drugs, devices, and biologics, we're talking to all the manufacturers who might have options that could be used. We don't have anything in the immediate future other than the options that we're talking about here, which, as you can see, are becoming much more available. With regard to TPOXX, I know there's been a lot of discussion about it. It's really important, and I think you asked the question because you're well aware of this. This drug was approved for smallpox for emergency use, with a disease with a mortality of 30 to 50% based on the animal rule, which means it's never been tested in human beings or in people with disease. We think it's going to be effective in monkeypox, but we have no proof of that yet, and so it's critical as we roll it out through expanded access. And make no mistake, our goal is to make it available without excess bureaucracy and paperwork. But it's critical that we collect data because we don't know about the risk of the drug or the potential how effective it will be. So I appreciate the question. We definitely got to collect data, and we are planning a clinical trial, which we think is essential to lead to its eventual full approval.
Thank you, Commissioner. Is there anyone else who would like to jump in there from the speaker's line?
I wonder if Dr. Marks, if you might want to comment, if you're...
Dr. Califf, I think you've gotten this very, very clear. We're doing our best to look at all potential options to maximize the protection that we can provide the American public against monkeypox by maximizing the number of doses of vaccines and by making available whatever therapeutics are necessary that we can.
Thank you. Our next question comes from Cheryl Stolberg at the New York Times. Cheryl?
Hi, thank you for taking my question. I think I have two questions. The first, I think, is for the Secretary. It's my understanding that you can make two different types of declarations. One is a public health emergency under 319 of the Public Health Service Act, which I think you've done, but there's a separate declaration under Section 564 of the Federal Food, Drug, and Cosmetic Act. It's sometimes called an EUA declaration that would help the FDA speed the issuance of emergency authorizations. And I'm wondering, are you making that 564 declaration today? And if not, why not? And then separately for Dr. Walensky, I think, what does your modeling show about how quickly or how wide this virus is going to spread? Seems to be spreading by maybe 1,000 people a week. Do you know, say, several weeks or months from now, what that is going to look like?
So let me respond to the first question, Cheryl. The declaration today is the Public Health Emergency Declaration. 564, that's another animal and something we have to consider working with FDA and Commissioner Califf. But we will look at everything necessary to do what we must. And I'll let Dr. Califf give you some details, but in order for us to move forward with this promising approach with Jynneos, we would have to work with FDA to be able to make those kinds of moves. So let me turn it over to Dr. Califf.
Yeah, thank you, Mr. Secretary. And I'll just add quickly that we're feeling very good about the intradermal approach, and probably within the next few days, short period of time, we'll make a final decision about it. But it's looking good right now, and at that point, a 564 declaration would be needed to make it available because it's not the standard previous route of administration.
I think we'll turn to Dr. Walensky for any additional comments.
Yeah, thank you, Cheryl, for that question. You know, two things are happening at once that I think can account for the rise in cases that we're seeing. One is more widely available testing, and two is potentially more infections that are actually happening or a result of infections that happened 2 or 3 weeks ago. So it's hard to disentangle those right now. We do expect that cases will continue to rise as we've had more access to testing. People have had more access to testing before they go down again. And as we follow that, we will have more models available. Thanks.
Thank you. And I think we just have time for a few more questions. We'll turn to Liz White from the Wall Street Journal.
Yes, I was going to ask you to return to the question of what the strategy is if there can't be containment, and what makes you confident that containment is still possible.
We'll start with the Secretary.
And I will ask Bob Fenton to join in this one. I will tell you that we continue to marshal forward the tools that we need to make sure that we can take on monkeypox and keep it from spreading to the point of becoming endemic. We have vaccines. We will continue to receive vaccines. And with the very promising news that Dr. Califf is reporting, we may have even more than we expected in the near future. With the treatments that we have, certainly more than enough to handle the need. And with the expanded access to testing, we have all the infrastructure in place to do this right. We have a growing partnership with our local, state and local public health partners. We are, as Dimitri, Dr. Deskalakis pointed out, we have a growing partnership with the communities most affected. There should be no reason why we can't stay ahead of this if we all work together and we all take on our respective responsibilities. But let me see if Bob Fenton would like to add to that.
I think you did a really good job, Secretary. It's really going to take a whole community effort. We need to work across government, to private sector, to community-based organizations. You talked about the need to scale the production and distribution of vaccines, which we're working on, making testing more convenient, access to treatments, and really the biggest one is a unity of effort, engaging, educating, empowering communities impacted or at risk of contracting the virus. So we're working down all those efforts. The president, has tapped me to lead this response and has, given me every resource I need in order to support all levels of government. I think what you're seeing today is those resources being used in an accelerated response effort across the administration, and I'll continue to do that until we contain monkeypox.
Thank you. Our next question comes from Christopher Wiggins at The Advocate.
Hi, thanks for taking my question. Now that a public health emergency has been declared, can you explain what the administration is doing to reach populations that aren't in major cities for vaccination, treatment, and education? And as for the stigma, what's the administration doing around the messaging now that the public will connect the public health emergency with the LGBTQ community?
Thank you for those questions. We're going to start first with Dr. Daskalakis, and then also Dr. Walensky will turn to you.
Great. Thank you very much for that question. So I'll start by talking about how we're reaching beyond just the large cities. And I think a lot of that has to do with reaching specifically to community-based organizations that don't just serve large cities. really having engagement, especially in the LGBTQ space, with LGBTQ centers, many of which serve rural areas, as well as the work that we're doing through our partners, specifically focusing on providers of both social service as well as medical service. So our work that we're doing with HRSA and really sort of leveraging community health centers and making sure that knowledge is there. So really multi-pronged approach. Also, of course, having trusted messengers. So, in the age of social media, even in rural spaces, a lot of the social media and messaging does penetrate, especially when focused on individuals who are trusted voices to the community. From the perspective of the public health emergency, I think that from the LGBTQ perspective, this is a very clear statement of the value of the lives of people who are in the LGBTQ community. So I think along with moving forward and accelerating some of the work we're doing, I think it also represents an important commitment by the administration to the community. And I think since my first day doing this job, the president is so committed to making sure that we are engaged with gay, bisexual, and other men who have sex with men. And I think all of the folks on this call who represent agencies really are on the same page. So it's an opportunity for us to really be clear and to leverage the emergency to move faster, and also work as we have been to make sure our messaging is tight and is intentionally designed not only to be stigma-free, but to counter stigma. Thank you.
Thank you. And I believe Dr. Walensky may just want to add one point there. Dr. Walensky?
Yeah, I think Dr. Descalakis covered a lot of it. We've held over 15 webinars and listening sessions with key medical associations and professional societies, with community partners. We have weekly calls with healthcare and public health partners, as well as weekly calls with our Council for State and Territorial Epidemiologists. We've conducted 3 clinician outreach and community activity calls, or COCA calls. These reach over 64,000 subscribers and 100 COCA partners comprised of national, medical, and professional health and public health organizations, so reaching both urban and rural communities, frontier communities, and much of what Dr. Descalakis said with regard to reaching out to our partners in the LGBTQ community who have just been essential to get the message out.
Thank you. And I think we'll turn to the Secretary for one more thought there.
Yeah, I just wanted to add, and I may ask Administrator O'Connell to chime in, that to Christopher's question, we have from the beginning made sure that we have kept in mind all communities, including communities that may not be in the most densely populated portions of the country or aren't reporting as high a number of cases. We've tried to make sure we get to those areas of the country where there are high numbers of cases, but we don't want to leave people out. And so we have made sure that we have allocated vaccines throughout the country, through all jurisdictions. And Administrator O'Connell, you may want to add something more detail on that.
Thanks so much, Secretary. You said it exactly right. So we continue to make available the allocations that we have distributed, both to those that have high case populations and those that have high risk populations, to ensure that every state has access to this vaccine. And jurisdictions have access to this vaccine. You can find the allocation on hhs.asper.gov, and we continue to update that. Thank you.
Okay, thank you. And at this time, we're just going to be able to take one question. So after we answer this last question, we encourage anybody else who has questions to reach out to us at media@hhs.gov or to the White House with additional questions. We're going to turn to, Pian at NPR.
Hi, thanks for taking my question. I have a follow-up question and then a question about testing. So in terms of the follow-up question, in addition to the declaration of a public health emergency and the emergency use authorization, which is being considered, there's also a PrEP declaration that would provide a shield of liability for clinicians, and I'm wondering if that's something that's also being considered or declared today. And then separately, we've talked about expanded access to testing, seeing more tests come in, and I'm wondering how many tests are being conducted and what's the positivity rate?
Okay, thank you. It looks like the Secretary is going to start, and then we'll turn to one or two others.
Yeah, we may have a number of folks who want to respond to that. Let me just say that we gave a lot of thought to how we were going to proceed, what we were going to do in terms of vaccines. the outreach, trying to expand the number of testing sites available, how we make sure we distribute the treatments, the TPOXX treatments. All of this has taken a lot of thought and consideration and work with the White House, our other partners around the federal government, and of course state and local. So the same consideration will be given to how we proceed with regard to whether there is a declaration on 564 or whether we do something with PrEP. And so what I would simply say to you is that we are going to do what we believe is necessary, working with the White House coordinator to make sure that we're addressing the needs in the country on monkeypox. But let me see if someone else wants to give a little bit more detail.
Dr. Walensky, is there anything you'd like to add there?
No, the only thing, I was going to circle back to the testing question, if that's okay. So since May, we've seen a significant increase in the number of tests being performed week over week. In late May, we were at about 500 specimens tested per week to nearly 8,000 specimens tested per week in the week ending July 29th, with the number of specimens being tested increasing by about 3,000 from the week prior. As testing has increased, our capacity for testing has increased and far outpaced the demand, with our current capacity about 80,000 tests per week. So right now, we're really only testing in about 10% of the capacity we have, and we are encouraging anyone who has a suspected a rash that could be monkeypox to present for testing, and then, of course, encouraging providers to go ahead and send that test. I want to caution on the interpretation of percent positive, and that is because we are encouraging providers to take more than one sample per patient, and there's probably not a standardization in terms of how many patients, which patients get how many samples. We're encouraging at least 3 samples per patient. Of course, you test the rash for this, you swab the rash. So there is not necessarily consistency in the number, in the percent positivity, because patients have a different number of samples that are tested. Over.
Thank you. Well, it looks like we're at time, so we're grateful for all of you who joined us today for this conversation. We hope to be in touch later, and please reach out if you have any further questions. We hope you all have a good day, and we'll talk to you soon.